COVID-19. So just a little bit of background about Truth Initiative before I get started, for those of you who may not be familiar with us as an organization. We're the nation's largest nonprofit public health organization that is dedicated to inspiring tobacco-free lives from smoking, vaping, and nicotine. We have 4 major work areas at Truth Initiative. The first is public education, and that's, most people know us best for our award-winning National Youth Tobacco Truth Campaign, and I'm going to be talking a little bit about the Truth Campaign as part of the intersection with our cessation work. We're also active in research and policy through our Schroeder Institute, youth and community engagement, and the development and implementation of digital tobacco cessation programs, the work that I lead in the Innovation Center, as Pamela mentioned. So I'm going to be focused, as I mentioned, largely on our work through the Truth Campaign and also through the digital tobacco cessation products that we've had available and that we've been able to make available during the time of COVID. I am guessing that for most of you, webinar fatigue is a very real thing. Michelle was quite clear that I should try and be as engaging as possible. And so to that end, we're going to pray that the technology gods cooperate because I've got some video spots to actually show you examples of some of the work I'm going to be talking about. So preaching to the choir here, we've all known for decades just how deadly smoking is and the particularly devastating impact it has on lung and cardiovascular health, obviously head to toe impacts on health and well-being. And then COVID comes along and really amplifies these risks. Those of us in tobacco control have gotten very familiar with this statistic that 480,000 people each year, every year, year after year die from a tobacco-related illness. And in a lot of the conversations that I've had, maybe in the conversations that you all have, that number really has no context for most people. I think COVID and watching the death toll rise and people being very in tune with what 243,000 deaths actually means, I think has really helped to reinvigorate the conversation about smoking and lung health and the importance of behavior change. So the science here is evolving very rapidly. This is just a sampling of dozens of studies, of systematic reviews, of meta-analyses that have come out between March and today. These are small enough that you probably can't see the dates, but really they first started emerging in early March, and we've seen multiple reviews and syntheses of the literature really trying to understand what the risk is. And I think a lot of us probably had the idea that the link between smoking and a respiratory infection was probably a foregone conclusion, but it's obviously taken a while for the science to catch up. A lot of these studies have been rushed to print without the benefit of peer review. You'll see date a manuscript was received, date that it was an editorial decision just 2 or 3 days later, and the date that it went to print. Obviously, in an epidemic, the focus has been on getting information out quickly. We've seen a lot of studies that have suffered from missing data, smoking status just not being assessed in this sort of crisis situation, but also measurement and sampling issues. But over time, as more and more studies have emerged and the quality of the science has improved, it's really become clear that smoking is associated with the severity, the progression, and the risk of mortality from COVID-19. Statements from the World Health Organization, statements from the CDC, I've included links down at the bottom. The synthesis from the World Health Organization is really the best link, and the link that I provide for people who are asking how to stay up to speed on this evolving literature. There's far less data on the links between e-cigarette use and COVID-19 outcomes. We do know that vaping negatively impacts lung and heart health. It exposes users to a variety of chemicals in the aerosol that's produced by e-cigarettes. And we know that those chemicals cause lung inflammation and reduce the ability of the lungs to respond to infection. And so, you know, an obvious conclusion is that there's probably a link between these two. The exact biological mechanisms that link smoking and vaping and the SARS-CoV-2 virus that causes COVID-19 are not yet understood. There's been a lot of discussion in the media about ACE2 inhibitors and upregulation, downregulation. That's still work that's underway and a hypothesized mechanism. As that work is happening, it's really important to also stay focused on the role of behavior. And when we think about these behaviors, you know, we can imagine smokers and vapors congregating with others, sharing cigarettes, sharing vaping devices. You obviously have to remove a face mask to engage in these behaviors, exhaling smoke and vapor that contains respiratory droplets. We know that these are all potential pathways for virus transmission. And so thinking about behavior as it relates to the experience of COVID is also important. So that's a whirlwind of an evolving and emerging scientific literature. The Captain Obvious statement here is that this is an infectious disease that primarily attacks the lungs. And so not inhaling chemicals into the lungs is really the best way to protect lung health. Unfortunately, we've been in the midst of another epidemic now for over 2 years, with scores of people doing just that, inhaling chemicals into their lungs. So the latest National Youth Tobacco Survey showed an encouraging decline in youth vaping, down from 27.5% in 2019 to 19.6% in the data that were released in early 2020. But the fact remains that youth e-cigarette use continues at epidemic levels. 1 in 5 high school students vape, which is about the rate that it was in 2018 when the Surgeon General declared youth vaping an epidemic. Nearly 40% of young people are vaping on a regular basis. This is not simply youthful curiosity or experimentation. And among young adults, we've also seen an increase from 5.2% in 2017 to 7.6% in 2018. Vaping is most common among young adults when you look at all adults in terms of e-cigarette use. Fortunately, we've been at the right place at the right time with a widely available solution to help young people quit vaping. In the early part of 2018, as the Surgeon General had sounded the alarm bell, we were seeing a lot of conversations on social media from young people about wanting to quit vaping. Obviously, the concern was that young people were starting to vape, they were vaping at regular intervals, but we started seeing conversations from young people about wanting to quit. And you can see some of these quotes here. I'm not quitting, but just thinking about it's giving me anxiety. Someone needs to get me to quit smoking because between my Juul and regular cigarettes, I can feel the end of my life when I extend my arm out. Now, these are young people really struggling with the feeling of being addicted and wanting to break free. So we decided to use our expertise in digital tobacco cessation, which had largely focused on smoking cessation for 15, 20 years, to step into this space, even in the absence of a scientific literature, to deploy what we thought would be a relevant, accessible, technology-based approach for young people to give them the best available tools and tips and strategies to quit vaping. So we started with the peer-reviewed literature on treating nicotine addiction among young people to identify best practices. We talked with a whole lot of young people, current vapers, former vapers, to really get an understanding of what's unique about vaping. This shouldn't just be a find and replace cigarette and replace it with e-cigarette. We obviously wanted to create an experience that was meaningful, that was relevant, that was dialed into their experience, both in vaping and in trying to quit vaping. And we connected with our partners at the Mayo Clinic Nicotine Dependence Center to get their insights as they've seen more and more e-cigarette users coming to clinic for treatment. So what resulted from all of that work is a program called This Is Quitting. It's a text message program designed specifically for teens and young adults to quit vaping. It's grounded in best practices, and it delivers practical evidence-based advice about how to quit. We tailor the program by age. There's a different experience for 13 to 17-year-olds than there is for 18 to 24-year-olds. We tailor it by the device that they're using, which we gather during the onboarding process. And the program is tailored around their quit data if they choose to set one. We designed the program to be highly interactive, and we do that through a number of different mechanisms. There are keywords that we instruct users how to engage with that generate on-demand support. So at 2 in the morning, 3 in the morning, sitting on the bus, wherever they may be, if they're struggling with low mood or boredom or stress or a craving, there are keywords that they can enter to get tips and advice sent right to their phone. We also ask a number of open-ended questions throughout the program to try and engage them. The really unique thing about the program is that a lot of the messages have been submitted by previous users. We have a mechanism in the program itself that users can hit a Google form and submit their advice, their tips, their strategies, encouragement into this Google form, and we folded a lot of that into the program along with either their first name, their username, whatever name they choose to use when they sign up for the program. So the messages are written in the first person. They're designed to sound like an encouraging friend, and they're really designed to showcase the fact that lots of other young people are quitting, that lots of other young people are using this program, and that it's a program that's specifically for them to help them be successful. So we launched January 18th of 2019. We're coming up on 2 years, which is crazy to think about. We had no idea what to expect. We launched with a nice segment on the Today Show that aired on their, obviously their morning segment. And, we thought this is going to be largely an adult audience. And so, maybe this might not be the best approach to reach young people. What you can see is that first little bump is the number of 13 to 24-year-olds who enrolled within the first 24 hours. And that number is 2,000 people. About 10 days later, Mashable, the tech website Mashable, ran a story on their Snapchat channel, which resulted in over 22,000 young people enrolling in a 24-hour period. This obviously starts to give us a signal of the demand that's out there. The program, in addition to the messages that we deliver to young people, we also ask for their responses at 2 weeks, 1 month, 2 months, and 3 months after they enroll in the program to ask how their behavior has changed in terms of reducing the amount that they're vaping or whether they've quit. The paper on the right-hand side of the screen is a letter that we published in Nicotine and Tobacco Research, describing the program, describing this uptake that we saw immediately after launch, and with some preliminary data of the 3-month outcomes on that big bolus of people that enrolled in January. To date, we've had more than 217,000 young people enroll. We run numbers every Friday, and so this is as of last Friday. 129,000 young adults and 87,000 teens. We pretty consistently see between 250 and 500 young people enrolling each day. And that's been pretty consistent now for most of the duration of the time since we launched this program. The other thing to note is that engagement with the program has been consistently high. These are not kids who are just passively receiving messages. 70% set a quit date. The majority of them set it for the day that they enroll. These are kids who are pretty eager and motivated to get rolling with a quit attempt. About half use those interactive keywords that I talked about to get more out of the program beyond the scheduled messages. and 68% stick with us for the full 2-month duration of the program. I'll note when we first launched in 2019, we very deliberately made it a 1-month program and a very light touch with just 1 or 2 messages a day. And at the end of that 30 days, we had a message in the program that said, do you want the program to be shorter, longer? Do you want more messages, fewer messages? And over 80% of the responses that we got indicated they wanted the program to be longer. They wanted the program to stick with them. And so over the summer, we extended it to be a full 2-month program. In terms of behavior change, at 2 weeks, we see about 68% of respondents telling us that they've either reduced how much they're vaping or they've quit entirely. And at 3 months, we're seeing really promising signals of sustained behavior change with 20% reporting 30-day abstinence at this 3-month follow-up. These are all observational data, which gives us some signals. But obviously, I'll talk more about this, about the randomized trial that we're running in order to understand the causal impact of this program. So those are all the numbers. The thing that really keeps us connected to this work are the messages that we get back from young people. We get dozens of unsolicited messages each day back from young people using the program. They know that it's an automated program, but they reach out to let us know that it's helping. And so you can see some of the messages here. I know you can't really respond to this because you're a computerized program, but it helps a lot. I just flushed my Juul down the toilet, 1 step closer. If the producer of this app sees this, I want to thank you so much for your support. Love you. Thanks so much for all the help. I'm feeling confident already. The messages in the rectangular boxes are the unsolicited messages we get. We also ask users to tell us what they value about the program. And so the ones in the little cloud shapes are the responses that we've gotten to those queries. And we pretty consistently see 3 themes that they like that the messages are from real people. They like knowing that they've got someone in their corner. A lot of young people are quitting on their own. This is not something that they advertise in their peer group. It's not something where they know other people who are quitting. And so knowing that they've got somebody cheering them on. And then, this is a pretty consistent finding, I think, for lots of text message interventions, is that they're just a reminder that at a point in time, they had made a commitment to quit, and the messages keep them connected to that commitment. So as I mentioned, we are, I actually can't say running because we just completed, we have now completed the very first randomized trial of a quit vaping program. We've tested This Is Quitting among young adults to start. We were super fortunate to have the support of CVS Health Foundation to do this work. It's a 2-arm trial that compares This Is Quitting to an assessment-only control. And we conducted follow-ups at 1 month and 7 months after randomization. The 7-month endpoint is designed to roughly correspond to a 6-month post-treatment outcome. Our primary endpoint, primary outcome is 30-day point prevalence abstinence, but we're also gathering 7-day abstinence and continuous abstinence. We did a whole bunch of things to minimize dropout. As you might imagine, doing an assessment-only control, we were concerned about dropout, about differential dropout. And so in both arms, we send a monthly text message assessment that's incentivized. They get $5 if they complete it, to simply ask about their behavior. And both arms get those on a monthly cadence. And then we incentivize the 1 month and the 7-month follow-up completion. And then for anybody who didn't respond to either the online survey or a text message survey, we had research staff contact them by phone. And the paper down at the bottom is the protocol paper that we published back in May. So in terms of demographic characteristics, I actually don't think I included a consort diagram in here. So we randomized 2,600 young adults within about a 3-month period We started late December of 2019 and we finished mid-March. And these were Facebook and Instagram and Twitter ads that were recruiting young adults to a research study. So this is separate and aside from the program that we're running. For ethical reasons, I don't know, it felt uncomfortable for me to peel young people away from being connected with a treatment program to get them into a research protocol. And so we recruited research interested vapers who were interested in quitting in the next 30 days. So 2,600 young adults, and these are the sample characteristics. What you can see is a pretty even split between men and women, a diversity in terms of race, an overrepresentation of sexual minorities, and about a third who report financial struggles, either barely or not meeting basic expenses. In terms of tobacco use behavior, the vast majority are vaping daily or almost daily. 82% vape within 30 minutes of waking. We know that's a strong signal of dependence. A third report smoking cigarettes, and 65% report that they've tried to quit vaping 3 or more times in the past year. We asked a whole slew of dependence measures. These are just a sampling of them. But what you can see is for the hooked on nicotine checklist, well-validated measure of nicotine dependence, you scan down through all those percentages, and what you can see is that very high percentage of the young adults enrolled are endorsing these items. 94% who said they feel like they're addicted to vaping, 93% report strong cravings, 82% feeling irritable when they haven't vaped in a while. We have a manuscript that we're about to submit that will describe the sample characteristics in our enrollment process. There's just not a lot of data about young people quitting and what they look like and what their characteristics are. And so rather than waiting to fold this into our main outcome paper, we thought this would warrant a paper of its own. We've had a lot of interest from state and local governments, from schools, from school systems, health plans, who are interested in disseminating the program to the young people that they serve, interested in doing it a lot of times in a co-branded way and being able to customize the program. And so we quite nimbly stood up the ability to do this under a contract mechanism. Partners get a unique opt-in keyword that they promote to their young people, and that enables us to track enrollment on the back end. We work closely with them to develop and deliver promotional materials and then provide routine reporting to give them a sense of the uptake, certainly the engagement patterns and outcomes on their particular population of young people. And that's really been a key channel that's helped us to increase the reach of this program. We've also integrated This Is Quitting into the Truth campaign to leverage the power of the brand to reach young people. When we first launched, we were running this program separate and aside from Truth. And then late last summer, it just became obvious that there was a real demand and a real opportunity for us to fold these two together to really take advantage of the Truth voice and the Truth brand to connect with young people. So just a snapshot for those of you who are not familiar with Truth. This has been one of the most successful youth tobacco prevention campaigns. And the real secret weapon comes down to a little bit of mischief combined with a whole lot of relevance. And so over that 20-year period, the campaign has worked really hard to stay in touch with and in tune with what's happening in youth culture to reflect that back in its messaging. Obviously grounded in facts to help young people fight the forces and impacts of nicotine addiction. But the intent is for the voice to be youth-led, to not be finger wagging or angry or condescending, to really be peer-to-peer in a clever but not silly approach. And so you'll see from some of the work that I'll be showing, it's also, there's also a bit of subversiveness, which we're okay with when it comes to the tobacco industry. So let me show you one of the spots. So the first integration of This Is Quitting into the Truth campaign came in the form of animal spokespeople in tested on humans. So we know humans often speak out about companies that test their products on animals. And in tested on humans, we really turn the tables to feature, I did not know this was such a thing, but there are animal influencers. Doug the Pug on the right here is one. He has over 3 million followers. And so we took these animal influencers and had them deliver this message to warn e-cigarette manufacturers to stop testing a product with unknown effects on young humans. And so let's take a look at tested on humans.
In a wild turn of events, animals are demanding Juul not test on humans. Mario?
No one knows the long-term effects of juuling, so any human who uses one is being used as a lab. Thank you.
Hopefully the audio came through and you got a flavor for it. So while tested in humans was in market and doing really well, we also began to see another phenomenon happening all across social media. And those were videos of young people literally destroying their vaping device. A lot in a last ditch effort as a way to quit, but really creative, clever ways of destroying their Juul. And you can see here some of what we captured at that time. Day 4, trying to quit Juul and I want to headbutt a steak knife, trying to quit nicotine, but literally 120% of the people I know have a Juul. And the one in the bottom right is a video of a girl who takes an axe to her Juul, really as a last ditch effort. And so, you know, we love it when an idea comes straight from youth culture, especially when we have a solution to offer. And so we jumped on this cultural phenomenon to create Ready to Ditch Juul, which launched in January of this year. And it combined this insight that young people are fed up with nicotine addiction, they're wanting to break free from their device. And here we put a call to action in front of them to join This Is Quitting. So it's interesting how history gets played out. You can see that said joined 70,000 and quitting, and you saw we're up at 217,000 not quite a year later. So the demand has continued. We've also responded directly to the pandemic. We recently launched an effort titled Vaping versus Immune System that is designed to explain how vaping can damage lungs and weaken the immune system. And here we partnered with Dr. Cedric, he's known as Jamie, Dr. Rutland, who's a pulmonary and critical care physician at the University of California, Riverside. He's got a massive youth following on social media where he really engages with his audience about all different kinds of health information. And so we took his following and his ability to connect with young people to focus on the links between vaping and lung health. So evaluation is at the crux of all of this work. We've been pleased that in a pretty short period of time, we've already seen shifts in young people's attitudes towards e-cigarettes. And this is really, keep in mind, in the context of a phenomenon that had been increasing in prevalence during the time where we were running these campaigns. So, really running a media campaign that's swimming upstream in a sense. But our evaluation efforts have shown that young people who are aware of the Truth campaign are significantly more knowledgeable about vaping risks. They have stronger anti-industry sentiment, and they find vaping less appealing and less socially acceptable. So some of the interim endpoints of knowledge and attitudes that we anticipate will translate into behavior change. We're still in the field collecting those data, but should have those findings over the next couple of months. All right, so let's shift gears now to talk about our tobacco cessation work among adults. I don't know if you all are hearing this in your work. We hear quite a bit this idea that, tobacco isn't a problem anymore. Who even smokes anymore? And it's largely because smoke-free policies and laws have quite literally pushed smokers out of sight. You all know these numbers. 20% of US adults use some form of tobacco. Many are dual users. Cigarettes still top the list. E-cigarette use has been pretty flat among all adults, but as I mentioned, among young adults has really increased in prevalence. Getting smoking rates down to 13.7% has been a true public health achievement, but there are still dramatic disparities in smoking rates. This is a chart from the CDC that really just shows across each of these demographic categories that there are still groups that have not seen the same declines in tobacco use that have benefited the rest of the country. And some of these rates are actually where smoking rates used to be nationally 15 to 20 years ago. So there are many tobacco cessation treatment options available these days, and each has their strengths and limitations. Ultimately, the ability of any program to make a public health impact is going to be a function of the number of people who use that program and its ability to deliver an effective experience that actually promotes abstinence. So I've got a chart that I'm going to run through here that just kind of lays out the strengths and limitations of the different approaches. So we know face-to-face treatment can be very effective, but we also know that a minority of tobacco users engage with this kind of intervention. And it's typically time limited, which just isn't how nicotine addiction works. Medications are effective. We all know they double the odds of abstinence. They should absolutely be part of any tobacco cessation solution. But we also know that only about 1 in 4 smokers will use any form of pharmacotherapy. And so a medication-only approach really misses the mark in terms of combining the proven and additive effect of behavioral support. Quitlines have really been the mainstay for population-based treatment for decades. They're effective and have done great work in really getting treatment into the hands of tobacco users who might not otherwise access treatment. But it's been getting harder and harder to get people to pick up the phone. Just changes in communication preferences have really impacted the utilization of freely available, widely available Quitline services. One of the innovative things that has emerged in the past couple of years have been CO monitors, typically linked to a mobile app. And so this is taking a device that we've all used in tobacco cessation research in terms of validating self-report out of the research laboratory and using it as another form of biofeedback with the notion that, presenting data on the health impact of smoking, making it more salient, may lead to quit attempts and to more sustained quit attempts. There's some interesting data. This is early in terms of uptake and appeal, but something to watch. And then the last category is mobile apps, and there's certainly been a proliferation of mobile apps. Here too, the evidence is still quite uncertain. There was a very well done, tightly controlled randomized trial that was just published, I think back in August or September, that demonstrated the effectiveness of a mobile app anchored around acceptance and commitment therapy. That was Jonathan Bricker and his group. But overall, as a category, the 2020 Surgeon General's report noted that there just hasn't been enough evidence for mobile apps as a class of intervention to note them as effective. So let me pivot to the work that we're doing here at Truth Initiative and talk about Become an X. And I'll just note the website is becomeanx.org. So this is a free tobacco cessation program that we've run since 2008 that we developed in collaboration with Mayo Clinic. The program is accessible on any web-enabled device. There's nothing to download to your phone. And it allows users to engage through a range of modalities based on their preferences and their needs. And I'll talk a little bit more about the technology behind it shortly. So it includes web-based educational content, interactive tools focused on helping users build the skills and the confidence that they need to quit, to create a personalized quit plan. We've run a text messaging program as part of Become an X for about 10 years now, and recently completed work to fully integrate it into the website. So a lot of times you'll see web and text programs that largely operate in parallel, where a user may fill out a web form at the start of enrollment, and it's that information from the web form that drives the tailoring. And so that's static one-time tailoring that may inform an initial iteration of the program. But the work that we've done through a NIDA-funded grant was to really integrate these different technologies in a way that dynamically tailors content over time. So as a user's needs change, as they move through the quitting process, the messages change with them. And I'll talk more about that shortly as well. We provide expert advice from Mayo Clinic tobacco treatment specialists. They've been a real partner throughout this work since 2008, and their expertise is really woven throughout all the different components of the program. And we have the largest and longest running online social network that provides peer support 24/7. So you can see since we launched in 2008, we've had over 900,000 registered users. We typically see between 2,000 and 3,000 tobacco users register each month. And that's also been pretty consistent over the years. Let me just do a time check here. Okay. So this is a snapshot of our member demographics. You can see the largest proportion are between the ages of 31 to 64. That's not surprising. That's typically when most tobacco users start thinking about quitting and reaching out to really make a treatment-informed quit attempt. We also see that about a third of our users are in that young adult bracket between 18 to 30, and that's been steadily increasing over recent years. The majority are everyday tobacco users, and interestingly, we see about 20% coming from rural areas, and I'll talk about that on the next slide, but an interesting representation. These are not simply folks living in cities who have great bandwidth, but a distribution across geography and across the US. The things that I want to really focus on, so the bottom two charts show that nearly half our users have a high school education or less, and about half have an annual household income of $35,000 or less. And so that really mirrors the groups that we know from that earlier slide, from the CDC slide, where smoking rates are still at their highest. We've published 2 studies that have specifically evaluated the generalizability of our users to national samples of smokers. We get this large volume of people looking to make a quit attempt to do it in a way with support. And so I was interested in how do our users compare to, let's say, folks in the National Health Interview Survey or a NISDA data set? And so those are the two papers that I'm showing here. In the first study, we used data from a randomized trial that I had funded by the National Cancer Institute, and we looked at about 5,300 participants. These were folks that we recruited at the time that they enrolled on Become an X, and then randomized them into a fully online trial. And we compared the characteristics of those 5,300 people to data from the National Health Interview Survey. And what we found is there were very few differences. We looked at a whole slew of demographic characteristics, and there were very few differences except for the fact that our sample had a higher proportion of daily smokers and a higher proportion of heavier smokers, which probably reflects that these are treatment-seeking smokers. But across all the other demographic characteristics, they were really reflective of that national data set. And then the second paper, we used data from the National Survey of Drug Use and Health to look at whether rural smokers were underrepresented on our platform. So there's often a concern about digital access in rural communities, and we were interested in seeing if there was an underrepresentation of rural smokers on X. And so we looked at the proportion in that NISDA data set living in urban, suburban, and rural areas, and we compared those proportions to what we were seeing in our data. And here we're using data on the full volume of registered users. And what we found is that not only were rural smokers proportionally represented among our users, they were actually overrepresented. We had a higher proportion than you would expect from looking at NISDA data. So you take the large volume of users that we have, the fact that they're reflective of tobacco users nationally, and our ability in-house to run pretty complex trials. And what that's translated into, fortunately, has been a good bit of success in competing for NIH funding. We've been funded from a range of institutes, which really signals, I think, their interest in funding digital tobacco cessation research in general, but also, the work that we're doing on our platform in particular. We've disseminated this work in publications that are specific to X, and obviously been asked to share a lot of this in invited presentations, grant review panels. So all of that, I've pulled out two studies that I wanted to focus on just to give you a sense for some of the research that sits behind this platform. So in 2015, we were awarded one of 6 R01s that was funded by the National Cancer Institute under an RFA focused on the role of social media in tobacco, alcohol, and illicit drug use. And one of the key findings that came out of our work was demonstrating the impact of online community engagement on abstinence. There's been lots of research done in social support and how to implement a social support intervention. A lot of the reviews have shown it's hard to manufacture or teach or coach or guide different kinds of social support. And so here we have this thriving years-long online social network of people who come together of their own volition to give and receive social support. And so the primary question that we were interested in asking was whether that translated into abstinence. And so we took the data from that randomized trial of 5,300 people that I talked about. And this was a really fun partnership that I had. My co-PI is a computer scientist from the University of Iowa who brought social network analysis and topic modeling and sentiment analysis to this data set, where we were able to construct the network that these trial participants were embedded in within the X community, who they connected with, how they connected, the content of those connections, the duration of those connections, in some pretty sophisticated social network analyses to then link them to the behavioral endpoint, which we had by virtue of this randomized trial. And what we found is that in prospective analyses, that smokers who were active in this online social network were more than twice as likely to quit as smokers who didn't participate in the community. And this was accounting for a whole host of other covariates and self-selection bias. We saw the strongest effect for those who actively posted and engaged with other people, but we also really interestingly saw an effect for just lurking, for people who get in and read, but who never actually interact with somebody else in the community. And we also saw that staying active in the community for a longer period of time was also a prospective predictor of abstinence. And that work, I have the citation down at the bottom. The other study that I wanted to talk about, so this was our text messaging study that was funded by the National Institute on Drug Abuse. And this really showcases, I think part of the interest at the federal level in this platform is that we're able to take what we're learning from our research and fold it back into a program that we run as part of our public health mission to directly benefit our users. So really a direct path in terms of disseminating what we learned from federally funded research. So this was a two-phase MOST design trial. We've published the results from the first phase. So this was a full factorial randomized trial that involved 864 new registered users on X who had signed up for text messaging. And we were testing different features of the text message program. I'm not going to go into the details here. Ultimately, what we found is that the combination of all four of them had the biggest impact on driving engagement with the program and ongoing engagement. And so that implementation, that version of the text message program is now the standard offering for anybody who registers on X. So in 2017, we really wanted to build on our reach through this program and to address a gap in the market. And so we launched an enterprise version called the X program, which we specifically designed for employers and health plans. So this has involved a really massive amount of work to expand both the features available to users, but also the ability to deliver service in an enterprise market to health plans, to covered entities. Obviously, that meant a shift over to a HIPAA compliant platform. So the user features that we've added are one-on-one digital coaching through live chat and pharmacotherapy decision support, and also pharmacotherapy delivery. The program here, again, is free of charge to users. Their access is covered by their employer or their health plan. And so we support clients in administering this benefit under the Affordable Care Act. Again, we give them comprehensive reporting about how their employers and members are using the program and the outcomes. I'll just note, so the way that we talk about this work, it really embodies this double bottom line where we're able to expand the reach of our program while at the same time generating revenue to help support our mission-driven work. I think I'm going to skip through this just in the interest of time. So this is just a snapshot. We've contracted with over 60 employers and health plans across the country, which represents over 6 million individuals who now have access to comprehensive digital tobacco cessation services. A lot of these entities serve Medicaid and Medicare members, which gives us reach to those priority populations that I was talking about earlier. We have a number of large employer clients. BAE Systems is a big defense contractor. You may be familiar with Laz Parking if you've used a parking garage recently. And also Virgin Pulse, which is the largest global digital wellness company. I'll just note we've seen a lot of growth and a lot of interest during COVID, specifically because we're a digital platform. We're able to get treatment into the hands of people regardless of where they are, especially now with remote work and people sheltering in place. And we're able to get this program out and launched relatively quickly. There's not a big delay once we've contracted with any of these entities. So I'll just close by noting that we have internship opportunities available 3 times a year. These are 13-week positions that are available all throughout the organization. And the links to the internship page and also our career page for job openings are down at the bottom of this slide. And so with that, again, thanks for the opportunity to present this afternoon. And I think we have time for some Q&A.
Thank you, Dr. Graham. So I want to open it up for discussion. And I think we have a couple of questions that some of our colleagues sent to me privately. One question is about the survey that was done for young adults. And the question is, within 30 minutes of waking the young people vape, is it in the morning or and after any nap at any time of day or night? Do you know how that question was described?
Yeah, so that's a pretty standard question that's been used really as a single item marker of dependence. And it's worded quite vaguely, but it references after waking. And so the presumption is that this is typically after, whether somebody's sleeping at night, whether they're sleeping during the day, depending on their work shift, but after a prolonged period of abstinence during a night's sleep, the extent to which they may be in withdrawal, which then triggers using tobacco within 30 minutes.
Great.
I have a question. First, I just wanted to let you know, I'm not sure if you're aware of this, but Rutgers is the recipient of a grant from the Truth Initiative. So I just want to personally thank you. The grant is to help Rutgers to improve its policy on tobacco use on campus. I know Truth has provided grants to a number of universities to do this, and ours is called Are You Tobacco Free? Okay. So we're actively engaged in trying to make this happen here at Rutgers. And one quick question that I was just curious about is the This Is Quitting app. Is this something that anybody could use or we could use and try to encourage Rutgers students to take advantage of that?
Absolutely. Yes, please. All the affirmatives. Yes, so it's a freely available program, easy to enroll by texting in ditch vape, all one word, to 88709. That may be part of the materials that you've gotten as part of the grant, but certainly happy to connect you. And we've helped provide materials to other grantees to help get the word out. So we can certainly do the same.
Great. Yeah, we're relatively new in the process. We're just getting some students onboarded, and they're going to go through some training. So we have more to do, and I'm sure that's part of the training that we are about to receive.
Yeah, absolutely. Happy to receive as many users as you can send our way.
Hi, I also have a question. My name is Nicolette. I support Kevin in the Are You Tobacco Free initiative. And I was very excited to see you mention the TikTok challenge. And I wanted to let you know that we're actually currently launching a TikTok challenge, the hashtag Immune Up Vape Down Challenge.
Okay.
So we're, launching it, but, I, of course, saying that it's Truth's TikTok challenge. And we just wanted to know if you have maybe any suggestions on how we can boost recruitment for that. If you're aware of how we can, make sure that we're appropriately marketing that TikTok challenge.
Is there a call to action as part of it?
Yes. So we've directly linked the Truth website, but just if you have any suggestions on how to kind of get more participants.
Yeah, not my wheelhouse, but happy to connect you with the folks in our marketing department.
Okay.
Talk through some of the key things that we found to be successful in getting young people engaged
Wonderful.
in different social media platforms.
Okay, thank you so much.
Sure thing. So Michelle, what would be the best way for any of these follow-up conversations? I guess, do people have my email on an invite?
I can pass around your email to all
Yeah,
attendees.
let's do that. Okay.
So I think if there's no more questions, and we can, if nobody minds staying an extra 10 minutes, we can certainly continue the discussion. But if not, I'll just follow up with an email with Dr. Graham's email address.
And I just have to note that one of our Truth Initiative alumna is with you, and a specific hi to Ollie.
Mhm.
Hi, Amanda. It's good to see you.
Good to
Even
see
though
you
you're
as well.
you're this big, but it's
I
nice to see
know.
you.
I know. And I'm in my office, if you can't tell. And
Oh, that's funny. I didn't realize that. Are you alone? Is it like a no man's land?
yeah, you can see the orange on the wall.
Yes, there you go.
That's the dead giveaway.
Yeah.
I'm the only one here, and the front glass doors and windows all have bulletproof and shatterproof stuff on it, which is a little unnerving. But apparently that's life in DC these days.
Yeah. Wow.
Hi, this is Elizabeth Brewer, GSK Consumer Healthcare. I have to run, but Dr. Graham, I really appreciate your presentation today. It's always informative, and it's really good to know what tools are out there that patients and consumers can use to help quit. So thank you for your time today.
And thank you. Good to see you. Thank you for making the connection. I know we've had many conversations over the past couple of years. Good to see you.
Yes, we have. Have a great day, and please stay safe. Thank you.
Thanks. You too.
All right, so I guess we'll just.
I'll ask the question. Hey.
Hi.
Hi. Thanks again for your talk. I just wanted to ask if you recommend or provide resources for young adults to take pharmacotherapy, even if it's over the counter, for those who enroll in the support program?
Yeah, that's a great question. So I mentioned we have two different versions of This Is Quitting. One is for 13 to 17-year-olds, and the other is for 18 to 24-year-olds. And how we address pharmacotherapy is really one of the major differences between them. So for 18 to 24-year-olds, we talk about the fact that medication can help make quitting more comfortable, that it's available over the counter, the different forms that it comes in. And for 13 to 17-year-olds, it's a very light touch. Talk with your parent or your healthcare provider. There may be medicines available that can be helpful, obviously, because they're not approved and physicians are using them off label right now.
And then do you track the outcomes by who may have or be on pharmacotherapy?
So for the 217,000 enrollees, we don't know that. That's not one of the things that we assess during the program. For the young adult trial, we do ask about medication usage along with other kinds of methods at both the 1 and the 7 month. And so we'll be able to account for that in our analyses.
Great. Thank you.
Sure thing. Our Brady Bunch board is shrinking.
All right, if there are no more questions, I will pass around Dr. Graham's email. And thanks for joining, everyone.
Thank you.
Thank you very much. That was great.
Thank you. Have a good afternoon and be safe. Happy Thanksgiving.
Hi, Amanda.
Bye-bye.